Hello everyone, welcome to my channel. In today's lesson, we are going to be talking about chest tubes. And like other forms of pleural drainage, a chest tube is placed in order to remove either air or fluid from the pleural space and to restore normal intrapleural or intrathoracic pressure so that the lungs can re-expand. It is very important that we understand the functioning of different models of chest tube drainage so that we're able to provide safe and effective care to our patients. A chest tube is a catheter that is inserted into the pleural space of the chest cavity in order to remove air, blood, or fluids. Patients may need one or more chest tube inserted for various reasons. A patient with a hemothorax will need a chest tube inserted because they have a collection of blood in their pleural cavity that needs to be drained, and this could be as a result of an open chest procedure that they've done or some kind of blunt trauma that they have experienced. Other patients will need a chest tube inserted because they're having a pneumothorax. And this is where there is a collection of air in the pleural space. We'll also talk later about tension pneumothorax, where there is air that builds up in the pleural space and it forces the mediastinal to shift. And this leads to a decreased venous return to the heart and it causes the lung to collapse or compress. And this is a very serious, life threatening respiratory and cardiovascular complication. Other patients will need chest tube inserted because they're having pleural effusion. And a pleural effusion is when there is a type of exudate or transudate in that pleural space, and it can be caused by heart failure, malignancy, pneumonia, lung abscess, or heart failure. A chylothorax is a type of pleural effusion, and it results from lymph that is formed in our digestive system, and that is also called chyle. And this accumulation in the pleural cavity can be as a result of either disruption or obstruction of the thoracic duct. Other patients will need chest tube inserted because they're having empyema. And this is when there is a collection of pus in that pleural cavity. Now, it is normally associated with pneumonia, but it can develop after thoracic surgery or thoracic trauma. So, you have now been asked to prepare a patient's bedside with the items or equipment that are needed for a chest tube insertion. So, you'll make sure that you have your pre sterilized packaged chest tube insertion tray as well as the pleural drainage system. You will get 1% or 2% lidocaine solution and a small gauge needle. You will ensure that the suction equipment at your bedside is working, and you'll get 1 or 2 waterproof transparent adhesive dressings. You'll also ensure that there's a stethoscope at the bedside as well as a 500 ml bottle of sterile water. You will also ensure that you're getting sterile gloves, gown, mask, and 1 to 2 sterile towels. If suture equipment is not in the tray, you'll need to get suture equipment or material and a scalpel blade. The placement site for a chest tube will be based on the medical condition that the patient has, as well as contents that need to be drained from that pleural space. If a patient is having a pneumothorax and there needs to be air removed from the pleural space, the chest tube is placed higher within the thoracic cavity because air rises. On the other hand, if it is that the patient is having blood or some other type of fluid in their pleural space, the chest tube will be placed in the lower posterior or lateral chest in order to drain this blood or fluid because fluids tend to settle in the lower cavity as a result of gravity. Chest tubes are also placed post-operatively after cardiac surgery in order to eliminate mediastinal bleeding, and these catheters will be placed through incisions near the inferior aspect of the sternotomy incision. These will only be in for 48 to 72 hours unless there is more drainage than usual or there continues to be active bleeding.
This is another diagram that shows the different placement site for chest tubes. We'll always follow our hospital's policy and the manufacturer's direction whenever we're setting up, monitoring, or using chest tube drainage systems.
We're now going to be talking about two types of drainage units, the water suction and the dry suction. The image that is displayed right now shows an example of a dry suction chest tube drainage system. These units use a mechanical check valve or regulator control dial to adjust the level of suction. The other type of chest tube drainage system is the water suction unit. These units use water in the suction control chamber in order to control the suction pressure. In these types of unit, there are one-way valves within one or multiple chambers that help to remove air or fluid and also prevent the return of the air or fluid back into the patient. This is an example of a wet suction chest tube drainage system, and you could clearly see the three chambers. You'll see the fluid collection chamber, your water seal chamber, and then the suction control chamber. We will now talk about the two types or variations of the suction control chamber. This can be wet or dry. A dry suction system uses a self-controlled regulator that will change or adjust the amount of suction and respond to air leaks to deliver a consistent amount of suctioning to the patient. On the other hand, if the patient is ordered suction, a wet suction system will be controlled by the water level in the suction control chamber, and the MD will usually order the suction pressure. Always remember that if there is less water, there's less suction. The amount of suction will vary and it will depend on the patient. It is controlled by the chest drainage system and not the suction source. You will monitor the fluid level to ensure that there is gentle bubbling in the chamber. Another point to note is that if suction is discontinued, that suction port on the chest tube drainage system must always remain unobstructed and open to air so as to allow air to exit and minimize the development of a tension pneumothorax. The water seal chamber has a one-way valve that allows air to exit the patient's pleural cavity during exhalation and prevents air from re-entering during inhalation. The water seal chamber is filled with sterile water and it should be maintained at the 2 centimeter mark in order to ensure proper operation. This level should be checked regularly and filled with additional sterile water as needed. A normal finding in this water seal chamber is what we call tidalin. And this is when the water in the water seal chamber will rise with inhalation and fall with exhalation. This tidalin lets us know that that chest tube is patent, it's working as it should be. Continuous bubbling in that water seal chamber may indicate that there is an air leak in either the patient's thoracic cavity or some possible tube disconnection. Vigorous bubbling can also indicate that there is some disconnection in your tubing, and absence of bubbling could let you know that the tube is kinked. Of note is that a normal finding for patients with pneumothorax is intermittent bubbling, and that tidling should stop once the lung is reinflated. There are some chest tubes which have really cool safety features, such as the air leak monitor. An air leak monitor meter is shown below, and you'll notice that it is made up of numbered columns labeled from 1 low through to 5 high. The higher the numbered column, or the higher the number through which bubbling occurs, the greater the degree of air leak. You will document the number at which bubbling is occurring, and you'll monitor the increase or decrease of the air leak. Bubbling should always be from the right to the left to indicate an active air leak. An air leak in the water seal could indicate that air is re-entering the patient's pleural space, which can indicate worsening of a pneumothorax. The collection chamber is the largest chamber, and it is typically on the far right of the system. The chest tube connects directly into this collection chamber, and it will collect the drainage from the pleural cavity. This chamber is calibrated to measure the drainage, and the outer surface has a write on, and you'll be able to mark at the start of your shift and also mark again the amount of drainage at the end of your shift. You will note the color of the drainage, the amount, the type of fluid that it has been drained, and the consistency of the fluid that has been drained. If it is that the chest tube is, of course, placed because it's draining some pleural fluid. A chest x ray will be ordered before the chest tube is inserted, after the chest tube is inserted, and after it is removed, as well as if there's any serious complications or change in patient status. Chest tube dressings are changed every 72 hours, and PRN if it is that your dressing becomes soiled. You never reinforce these dressings, always just change them. You will maintain sterile technique. You'll cleanse the site with chlorhexidine stick, let it air dry. Then you'll wrap some adaptic around the site, between the site and the tube. Then you place a 4x4 trait gauze, cover it with a 4x4 gauze, and then you'll secure it with some Medipore tape or Tegaderm. For patients who have chest tubes, you'll monitor their respiratory status, assess their pain, monitor the insertion site for bleeding and infection, and you'll also monitor the insertion site for development of subcutaneous emphysema or crepitus. You'll also monitor for pericardial effusion or cardiac tamponade. Purse string sutures are no longer the best practice, but if it is that the doctor did put a purse string suture, you will monitor the site for skin necrosis. As the primary nurse, you will review the patient's chart to ensure that you are aware of the reason the chest tube was inserted, the location, and the insertion date. By knowing all of this, this will inform you as to the type of drainage to expect and to the type of care that the patient may need to receive. You'll also continue to do your site and your dressing assessments, and you'll also continue to do your cardiopulmonary assessment. Frequent assessment of the patient will ensure that you are aware if the patient is stable, if their condition is resolving or it's worsening. And it also informs you to know that the chest tube is in and it's functioning correctly. You will also encourage the patient to do deep breathing and coughing exercises because this will promote lung expansion and promote fluid drainage. A semi-Fowler's or head of the bed at least 30 degrees is also recommended because it promotes easier breathing. If it is that you do have a patient who will be off the floor and they also have a chest tube, you will ensure that if the chest tube with suction is ordered, that there is also an order that will state chest tube to be drained by gravity if the patient is off the unit for procedures. To transfer a patient with a chest tube that can be drained by gravity, you will simply disconnect the tube from the suction port. If it is an order states that suction must be continuously applied, you will attach the tube to a portable suction machine. It is also best practice to ensure that all your connections are taped and secure according to your hospital's policy. Ensure that the tubing is not kinked or bent onto the patient or in the bed rails or compressed by the bed. You'll also ensure that even during transportation, that collection chamber or drainage system is always below the level of the chest and secured to prevent it from being accidentally disconnected or knocked over. Irrigation of chest tubes is rarely done. A physician order is required and it should specify which chest tube, especially if there are more than one, the frequency, the solution, the amount, the rate, and the purpose of irrigation. Irrigation of a chest tube can be performed by a nurse or a respiratory therapist. As a standard, we never clamp chest tubes. Reclamping a chest tube may lead to the redevelopment of pneumothorax or development of a tension pneumothorax. Chest tubes are only clamped if it is that there's a doctor's order to clamp or a valid reason. The tube must remain unobscured and unclamped to either drain the air or the fluid from the pleural space. There are, however, a few exceptions where clamping a chest tube is okay. That is, if you're changing the drainage system, if it is that you are assessing the system for an air leak, or if your tube or your system becomes disconnected. And if that is the case, it is much better that you place the end of that tube in a bottle of sterile water. The other reason that a chest tube may be clamped is if it is time for removal and the doctor will write an order and he will be the one that will come and remove that tube. So once the physician has reassessed the patient and they have determined that the patient's clinical status is improved, the lungs have re-expanded on test film, and the drainage is satisfactory, they will let you know that they are going to be removing this chest tube. Here are a few items that as a primary nurse you will need to get at the bedside. So you'll get a dressing tray. You'll also get Gelinet, Adaptic, or another type of non-adherent dressing. You'll get your chlorhexidine antiseptic solution. You'll get your suture kit with the cutters and the scissors. You'll get some 4x4 gauze. You'll also get Hyperfix tape, a blue pad, some Kelly clamps, your PPE, including your face shield, your face mask, and your non-sterile gloves. One of the major concerns with chest tube removal is developing a pneumothorax. And so after the chest tube is removed, as the primary nurse, you will observe for respiratory distress, subcutaneous emphysema, or bleeding from the site. Some physicians will order a chest x-ray within 4 hours of removal. You will just have to follow up with the physician to ensure that they have reviewed this chest x-ray, and you will document in the patient's chart that the chest tube has been removed, the patient's status. You'll also note the final amount of chest drainage to calculate the total drainage. As the primary nurse caring for a patient with a chest tube drainage system, it is very important that in monitoring your patient, you are notifying the physician immediately if any of the following occur. If your patient begins to have any dyspnea, hypoxia, or tachypnea associated with a large volume of chest tube drainage, this could indicate re-expansion pulmonary edema. Any restlessness, anxiety, as well as central cyanosis can indicate hypoxemia. And in addition to notifying the doctor, you'll also monitor their SpO2 saturation and initiate oxygen therapy as needed. If you notice your patient is having neck vein distension or jugular vein distension, hypertension, crepitus, or any change in their cardiac function, this could indicate that the patient is having tension pneumothorax. If you notice bright red blood or the presence of bright red blood that is new in their chest tube or their drainage system, this could indicate that the patient is having hemorrhage. Any subcutaneous emphysema, otherwise known as crepitus, in the surrounding area at the insertion site could indicate that air is leaking into the tissue and maybe the chest tube needs to be adjusted or reinserted. If you notice any increased drainage, inflammation, or exudate at that chest tube site, this could indicate that there may be some infection. In addition to notifying the doctor, you'll also get a sample of this exudate so it could be analyzed by the lab should the physician order this. You will also notify the doctor if there's more than 100 ml of drainage on the second day of post chest tube insertion. We will now talk about different complications that the patient who has a chest tube may experience, as well as interventions and orders that you could anticipate. If you notice that your patient is in respiratory distress or they're having pneumothorax, as evidenced by hypotension, tachycardia, or bradycardia, complaints of chest pain, decreased chest movement, asymmetrical chest movement, diminished breath sounds, increased respiratory effort, shortness of breath, and decreased SpO2, you'll notify the doctor immediately. They may order an urgent or stat chest x-ray, and you'll also prepare for either insertion of a chest tube or repositioning of the existing chest tube. You'll also ensure that you're checking your drain system to ensure that there are no leaks, blockages, kinks, or clamps. If there's bleeding, you'll first don gloves, apply pressure to the insertion site, place an occlusive dressing over the site, notify the doctor immediately, and he may order coagulation studies and complete blood count. You'll also check your drain chamber to ensure that there is no excessive blood loss, which could indicate potential hemorrhage. And the other point is that if there's any persistent bleeding at that insertion site, it could mean that that chest tube was initially inserted against a vein or an artery, which is very important that the physician will keep in mind if it is that they need to remove it. If you suspect infection because the patient is having fever, inflammation, drainage, or exudate at that insertion site, you notify the doctor who may order blood cultures and a wound swab. If for any reason your chest tube becomes disconnected, the best practice is to place the distal end of the chest tube in a bottle of sterile water. After which, you will clean the ends of the drain and either reconnect it or you will need to set up a new drainage system. You will next check the patient's vital, let the doctor know that it was disconnected, and he may or may not request a chest x-ray. If there's accidental drain removal, you'll apply pressure to the exit site and seal it with some steri strips, as well as place an occlusive dressing over the insertion site. You'll check your patient's vitals, immediately notify the physician who may order a chest x-ray, and this incident will also need to be documented. During removal, what may happen is that there is drain retained. And if this happens, if the tube just fractures while the doctor is removing it, or the doctor suspects that there are remnants of the tube that are left within the patient during removal, they'll immediately do a STAT or an urgent chest x-ray, and the patient should keep NPO if it is that they'll probably be going for surgery. You will also keep the entire drain tubing in the patient's room if it is that there need to be some quality review after, as well as ensuring that you're documenting according to your institution policies. And once again, thank you very much for taking your time to listen to this lesson on caring for patients with chest tube drainage systems. If you enjoyed today's content, leave a like, leave a comment, subscribe, and share with other nurses who may benefit from content like these. See you around next time.